The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety.
So, based on Radon Navant,
yeah,
I think the thing that I've struggled with this whole thing is I don't understand the situation that she's in. I'm not going to sit here and say I even know what it's like to work in a hospital as an RN, because I don't. Whether you're in the ICU or whatever. Only thing that I can take away is I try to put myself in that situation.
Yeah.
Okay. And I try to wrap my head around. So let me start by saying this. Do I think she should have been charged? Absolutely not. Do I think that there's medication errors all the time? Absolutely. Do I think that we try to do the very best? And before I say this, have you ever made a medication error?
No. Yes, absolutely.
So I don't know if I've made one actually me pushing the drug, but I know I've been involved in 2 medication errors where I did not push the medication either time. I was involved in the patient. I was responsible. I'll share with you both of them. Okay. All right. I want full transparency. So first one, I was a brand new paramedic. I hadn't even went through my field training officer segment yet. I'm working with 2 other paramedics, very experienced. I'm in the back with one of them. We're going code 3 back to the hospital with an anaphylaxis. Okay. Yeah. We had determined, hey, this patient needs epi. Back then, this was sub-Q epi. I drew up the epi, drew it up in a tuberculin syringe. I handed it to her, my partner, and I think I went to start an IV. No, IV was already established. I went to do something else. Didn't even pay attention what happened at that point. Maybe I was reassessing. Maybe I was listening to lung sounds. She gave the medication. We immediately noticed the patient clutched her chest. Now, this patient was like in her 30s. Thank God. Clutched her chest. Her heart rate shot up to 220, 230, and her blood pressure dropped.
Did you pull back on the syringe?
And I mean, guys, I'm telling you, like, I had just gotten out of paramedic school. I had never even, I wasn't even cleared yet. Right. And so I'm thinking this whole time where I'm like, man, they didn't tell me that the epi,
this wasn't in the book.
Sub-Q epi would work like this. I don't know if I'll ever give that again. I mean, she acted sicker after the epi was given than she did before. And I thought, man. So we show up to the hospital, we unload her, we get her inside, we come back out, and partner's partner comes up to both of us and goes, hey guys, how'd you give that epi? Now, I'm clueless. Like, I didn't see nothing. And partner goes, other partner just kind of, she goes, oh my God. She had given the sub-Q epi IV.
Yes.
Yeah. And so talk about, now this is way before Just Culture.
Right.
We called the supervisor, which he's still a close friend. And went inside, told the ER doc what happened. ER doc was like, that's no big deal. Sometimes we give it like that. And there was never another word said about it. Supervisor felt like it was fine. And I mean, I don't know if there was an incident report written or whatever. Again, I wasn't even honestly supposed to be doing patient care. I mean, honestly, on paper, I was. So that's one example where I learned really quickly that, I mean, you really right route, right? You got to go through those 5 patient rights.
Yeah.
The other one was in an aircraft, and it was with a new nurse I was flying with. And, it was just a difference of how a paramedic and a nurse do things. We, as paramedics, a lot of times will get Versed, right? 2 milligrams, and 5 mils. We'll push out 2 cc's of a saline flush. We'll pull in that Versed, and we got a 1-to-1. Yep. If you're going to give repeated doses, that's the easiest way to do it, and then you just waste it at the end.
I agree.
Nurses do not do it that way.
No, they do not.
Well, this was her first flight. I had already drawn it up. I said, hey, let's just give a little bit of Versed, And long story short, she ended up giving the entire 10 cc's, right? So that was a communication error. I thought I communicated effectively. Obviously, I didn't. I said 1 cc. She gave 10 cc's. And, ultimately, there was no harm, no foul. Patient was assisted with their ventilations for a minute or two. Patient was fine. Patient maintained a good airway and SATs, and it was all reported and taken care of. But those are 2 examples. But if I didn't feel like we could report those things or talk about those things, then yeah, I could see that being a big problem.
I could too, and especially like what you're talking about with I can't say her first name, but Vaught. She according to the story, she had gone into the Pyxis system. Apparently there was none of the medication that she needed or couldn't find some of the medication and ended up with vecuronium somehow.
Yeah, she typed in V instead of midazolam. She typed in V and or VE, and it populated VEC, and then she did an override on that.
Right. But at the end of the day, her patient died.
Yeah.
Your patient did not. And so I think that is one of those things. I'm not saying that both of those were not mistakes. I'm just saying that the consequences of one were much different than the consequences of the other. And so in a just culture, when you have the court system and you have a family and you have all kinds of people who are coming at you because their mother has passed as a result of your mistake versus too much Versed and bagging a patient until their respiratory drive comes back. Yeah. It's 2 very different things. Having said that, with just culture, I feel like it's important to take a big look at what happened, especially in this Vaught case in the news, is what exactly happened. Should she have had the ability to override that medication? I mean, that's essentially saying, yes, I know that this is wrong. Is what an override would be. Like, I realize that this doesn't fall within the normal parameters, but I'm going to do it anyway.
But it sounds like that's a very normal, common thing. Even Ashley was saying that things have to be overridden constantly on simple medications.
So in a just culture, though, that would be something to look at and say, this is having to be overridden all the time.
Right.
So it is a process problem, not necessarily
it's alarm
provider
fatigue.
problem.
It's alarm fatigue. Yeah,
absolutely.
Yeah, and that gets into a completely separate thing, where, Verkest and I talk about this all the time, where you start talking about, and I think in my mind, and maybe you guys might agree or not agree, when you start thinking about cognitive overload, one of the ways that is fixed is checklists.
Yeah.
Right. And I think that there's definitely arguments for checklists. Obviously, we use those in the flight environment. The pilots are using those as a double check. I also think that there's a negative side to that. I think that it really decreases our ability to critically think. I think it decreases our ability to have memory recall. And I think there's got to be a way to combine both of those. Mm-hmm. Right. And maybe that's human nature. I definitely think you need to have a checklist to verify that you're doing everything right or wrong. But I also think you have to hold the providers accountable to understand things to a point where they can critically think. My worry, and sometimes this is not a popular stance. I mean, I've argued with Ratu on this. I've argued with Mike on this, is I truly believe it's like, what if you're using your phone as a checklist, or you're using an app, or you're using a laminated card? What if you lose those? What's your backup?
So I got to ask you this question. Have you ever read the book, The Checklist Manifesto?
No.
You should read that book. If you haven't read that book, it's a great book. But, in that book, it even talks about some of the origins of checklists. And checklists were created back in, 1944, somewhere around there with the B-17s. Early on in the B-17 history, a B-17 took off and very quickly fell to the ground because there was an engine failure. And it was shortly thereafter that they decided, hey, we're gonna have these checklists to make sure that we're doing what we're doing. In that book, this is another name I can't pronounce, so I'm not even going to try. But the author of the Checklist Manifesto says you should memorize your checklists. You should learn your checklists so that you're not looking at your checklist and going down saying, I need to do this. Okay, let me see. I'm going to read, I'm going to know, and I'm going to do. That's not what a checklist is for. A checklist is more as a validation and a verification of the things that you already know that you're supposed to do. So I'm going to do these things, and then I'm going to get my checklist, and I'm going to say, I did that. Oh,
love that.
Wait, I didn't do this. And so that is your verification. So it is a combination of both of those things. But I
think that's missed. I think what you just said is missed. I think people, they don't do that. They're using it as a memory aid.
I agree with you.
And that is not the way I see to maintain a proficiency in whatever we're doing. I just don't, and I think it comes back to exactly the alarm fatigue. You get so used to, hey, I don't need this. They're probably not even reading those.
Absolutely not.
Right?
Yeah.
How many phone numbers do you have memorized that are in your phone?
One.
Okay, and that's a great example. I have a photographic memory with numbers. I mean, I do. And I used to be able to remember Social Security numbers.
Yeah.
Right? Not that way with spelling or words, but with numbers I am. And even me knowing myself, yeah, I've got a few. You know what I mean?
Yeah.
And that's a great example. We've relied on technology. We don't stimulate our brain. We don't stimulate our memory. If I did not have my phone, I'd be hosed. Yeah. In certain circumstances, something happens, I need to get a hold of somebody. There's going to be certain numbers that I had to remember a long time ago that I could recall. I don't have your number memorized.
That's the only number I have memorized is my number.
That's the thing. So I think that it goes back to that. And I think it comes back to, that whole alarm fatigue and that. I think what I've struggled with this case is putting myself, like, what could I relate to this? The only thing I could relate is I've given Versed. I've given Vec hundreds of times. Maybe she hasn't given Vec very many times. I'm sure she's given Versed. I think that's where I struggle. And this is where it's like, okay, we got to have just culture. We've got to look back at the education. Like, where is the education in the hospital for these nurses to where there's validation of competency, that they know the pharmacology and they know what they're administering. And that's a system issue, right? That's a hospital issue. That's not, I'm not faulting her, but I put myself, I'm like, would I ever, even if I did get to the point and I put in VE and Vec popped up and I got rid of that message and then the medication came out. I mean, maybe I'm delusional, but I'm like, at that point, I think I'd catch it. Even if I didn't at that point, once I realized I had to reconstitute the medication.
That's the problem.
That's where I'm struggling. And I guess that's where I try to, and Ashley will tell you this about me. We get into a little spat or argument. I want to know why we got in that argument.
Yeah.
Like, I want to go back and trace what caused us to get to this point, because I don't want to do that again.
Right.
Like I'm a root cause type of guy. She don't care about that. Like let's when it's over, it's over. And I'm very analytical like that. And so I guess I put myself in that situation. I'm like, okay, well, how did we get to that point? There was a lot of areas that broke down to that point. But I guess what are your thoughts? And it is what it is, right? Unfortunately, a patient passed away. We have to talk about this. We have to learn about this.
Yeah.
I might be completely wrong and I might miss that, but I guess I go back to my experience. And again, maybe it's because I've given VEC hundreds and hundreds of times to where I know.
Yeah. Oh,
maybe
yeah.
that's just not a common med for her. But then I go back, I'm like, okay, well, Versed is. I mean, nurses give Versed like it's water.
I agree with you.
That does not have to be reconstituted. The vial is not 10 milligrams in most cases.
Yeah.
Right? So you would think that there would be some level of, and then ultimately the assessment. Like, was there a constant assessment? So what are your thoughts?
I agree. Yeah, I agree that once I kind of knew the details of that, I was thinking those are two very different medications, given two very different ways. But, I felt like from a transport environment, I did the ordering for our base for a little while. And sometimes you get a medication that is not in stock and you have to get something else.
Yeah.
Which I think that's a whole nother conversation, but that can be problematic too, because now you're giving a vial that's the same size to somebody that's, 10 times the concentration.
You saw it all the time with Zofran and Benadryl.
Absolutely.
Yeah.
Absolutely.
Yep.
So in this case, once I heard that had happened, I thought, well, maybe she thought that it was just something different. Like there's a shortage of everything right now. So maybe there's a shortage of that.
Yeah.
But at the same time, I have to think to myself, it's very strange that regardless of the concentration, I'm having to reconstitute this when nobody ever reconstitutes that medication. And so should that have triggered something or should there have been a process put in place that said, maybe this is completely different from what I have normally done. And I need to have somebody double check this before I push this drug. I think it's important to have double checks.
Yeah.
It's why a partner, it's so important that, I even got into the habit, and I don't know if it was everybody's habit, to say, here's this medicine, double check it. Here, you touch it, have it, hold it, whatever. And that brings up another point about having it and holding it. Is it's super important to check out these drugs prior to and put your hands on them and be able to say, okay, this is Versed. It is in a vial. It is liquid. I don't have to do anything with it. This is VEC. This is a powder. I've got to reconstitute this.
Yeah.
Which also makes me wonder, there had to be some normal saline or some bacteriostatic water or something that had to be put into this to reconstitute it. So where did that come from? So I think it's just important that even in this time of shortage that we're living in, if you are having to give a medication, it's important to double check the concentration of that medication. And if it's something that you aren't familiar with or that you aren't familiar with that drug, it's important to have somebody else double check you before you push that drug into somebody's whatever.
Yeah. Again, I'm not trying to armchair quarterback. I think it is just, I try to put myself in that perspective, and maybe I would have made the same mistake.
Sure.
God forbid. I just, there were obviously many layers. I listened to a talk on this from Z-Dog MD, and he was talking about the same thing. I think there were so many layers there, and maybe the stars aligned. She was exhausted.
Yeah.
She was working. She had a new employee with her.
Yep.
Right. That was definitely distracting.
Exactly. And again, like Eric is saying, I'm not even trying to say, well, that seems just beyond the realm of comprehension. What I am saying is that in times like that, you have to understand that there are probably going to be lots and lots of distractions around you. And so if you're doing something and you think to yourself, this just doesn't seem right. It's just not the usual or whatever. I think it's important to have somebody else double check you. Again, in her situation, we have no idea. We have no idea. Like there have been plenty of times. I mean, we live in a transport environment, or we worked in a transport environment where 3 a.m. calls were fairly normal. And at 3 a.m., are you thinking like you thought at 12 o'clock p.m. when it's lunchtime and you're fed and whatever? No, absolutely not. So I think it's important to just have double checks in place. That's all I'm saying. Ms. Vaught, I'm not judging.
No, and I think, I've listened to the interviews. I've watched the interviews since. I mean, she definitely is super humble. She definitely is very apologetic, right? She definitely shows that remorse. I can't imagine, obviously the patient passed away, and you have to have compassion for the family, and
Absolutely.
You can't imagine what that would be like. But from a caregiver standpoint, right, we're all on one team.
Yeah.
And you have to think about the other side and think about the fear she had of possibly going to jail. Like, I can't imagine that. And the relief when the judge decided to sentence her to what he did and probation and deferment. And, I think that the thing that we can do is we can talk about this. And I think it's all right to have different perspectives and, talk about those tough situations. It's all right, I think, for me to, in my mind, think I wouldn't make that same error, because I think that also brings forth, well, maybe I would make the same error.
Isn't that part of just culture?
Yeah, maybe
it's
I would make the same error.
Yeah.
How can we prevent that from happening again?
Right.
Again, I think it comes back to complacency.
Yeah.
It comes back to being overworked. I know that there is a huge shortage across all disciplines in our industry. And I know nurses are being asked to see and take care of more patients per nurse. And I know that's a lot. Again, I can't say that I understand that perspective.
No, but we thank you.
Yeah, absolutely. So
Absolutely. Yeah.
So anything else on your mind?
No.
I want to say we got we're representing Life Med Alaska, our friends out there, and we got our Yetis and our coffee. So hope you guys are safe out there.
Yeah. It's too cold for me, but I will love you from a distance.
Yeah. Well, I think, guys, that's all we have. I think talked about a lot of good topics. We will continue to put these podcasts out. If you have any questions, you have comments, anything like that you want to talk about, we will definitely bring those up on a podcast. I do have a teaser. I did get an email, and we may or may not have this person as a guest, but he sent a few emails, and he's wanting my opinion on if mechanical CPR devices are something that should be part of the equipment for every air ambulance. I definitely think I have an opinion, and I'll share that on the next podcast. We'll talk about that, but I think there's a lot of ways to spin that, and I think there's a lot of ways to think about that. So that's definitely something that we'll talk about coming up.
Yeah, I think it's good.
All right. Well, on behalf of good old Evan Clonch over here, thank you again for joining us for the FlightBridgeED Podcast, and we will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.